Okay, good afternoon, dear participants. On behalf of the company Sphingotech, I would like to warmly welcome you to our webinar. My name is Cristiane Carvalho. I'm a medical science liaison at Sphingotech, and today it's my pleasure to welcome Dr. John Parissis from Greece. Dr. Parissis is professor of cardiology and emergency medicine at the Attikon General Hospital in the University of Athens, and he's the head of University Clinic of Emergency Department. His current clinical responsibilities refer to clinical evaluation and management of acute heart failure patients. Moreover, Dr. Parissis is co-chair of the Acute Heart Failure Committee in the European Society of Cardiology, and he has published more than 300 articles in the field of cardiology, acute cardiac care, and emergency medicine. Today, Professor Parissis will share with us how the novel biomarkers bio-Adrenomedullin and Proenkephalin A can guide the management of acute heart failure patients in the daily clinical practice. Last but not least, I would like to share a few information on this webinar. This webinar will be recorded and later available online. And during this webinar, please type your questions in the text field and we will address them in the Q&A session at the end of Professor Parissis' talk. With that, I would like to give the word over to Professor Parissis, and thank you again, Professor, for being with us today.
Thank you, Christiane, for this nice introduction. I would like to thank Sphingotech company for this invitation. I think it's very important topic, the role of new biomarkers in order to guide the optimal management of acute heart failure with cardiogenic shock in daily clinical practice upon the admission of patients to emergency department. Actually, I'm chair of the biggest emergency department in Greece. We have a lot of visits for acute heart failure, and also there are some cases of cardiogenic shock, and we need new tools for the optimal management of these patients. You can see here my disclosures, and I will start from the new guidelines of European Society of Cardiology for acute heart failure, the new classification. You can see here the 4 clinical phenotypes, 4 clinical scenarios of acute heart failure presented in the emergency department, the acutely decompensated chronic heart failure, in which in these patients there is a pre-existing heart failure, and acute pulmonary edema. This clinical scenario concerns mainly acute hypertensive heart failure. Finally, the cardiogenic shock, which is the more severe condition, at a small percentage of patients presented with isolated acute heart failure. This is the new classification. Personally, I think that the oldest classification based on clinical presentation of the patients according to signs and symptoms of congestion and or hypoperfusion is potentially more useful to guide the initial approach, because in this classification there is an overlapping between these 4 clinical scenarios. However, because acute heart failure is a condition with high mortality, not only in hospital mortality, but also after the hospital discharge and 1 year old cause mortality, you can see here that in patients overall, the in-hospital mortality is 5.5, but if you see here 1 year later, the mortality is about 5 times higher. That means that is a syndrome with needs special attention, special intervention in order to avoid further complication. Of course, the cardiogenic shock is the condition with the highest mortality. We can see here that in hospital mortality, cardiogenic shock is still 36%, while the other clinical phenotype with the highest mortality after the cardiogenic shock is the cold and wet patient with hypoperfusion and also congestion, but with history of chronic heart failure, not the characteristics of cardiogenic shock. Of course, the hypotensive patient is a patient with very high mortality, hospital mortality and long-term mortality. It means that we need tools in order to detect early the peripheral organ injury, especially in cases of hypoperfusion, to detect early the congestion, which is the pivotal factor that drives hospitalization in these patients early in order to apply the proper treatment and to prevent all these complications. Regarding the diagnostic tools, classically, the diagnosis of acute heart failure based on clinical examination, there is an great role of lung and cardiac ultrasound in these patients the last years. I think it's also a very useful tool in combination with physical examination. And finally, there is a role for space for natriuretic peptides for rule-out approach in order to exclude patients with acute heart failure. In these guidelines, there is also suggestion with some other biomarkers, especially procalcitonin for infections, and serum lactate remains also a useful biomarker, but I think this biomarker has many limitations in clinical practice. Regarding the natriuretic peptides as traditional markers, you can see here that there are many limitations in clinical practice, many barriers regarding the optimal use in clinical practice because their levels are affected by the age, the gender, the body mass index, the renal function, the presence of anemia, of atrial fibrillation, the timing of evaluation, the type of heart failure, either systolic versus diastolic, backward versus forward, the severity of the disease, and also the background treatment, especially in the case of use of beta blockers and sacubitril valsartan. This means that there is space for new biomarkers in order to detect congestion. On the other hand, if you see here the clinical definition of cardiogenic shock, in this classical definition with aortic balloon shock trial, there is also in this definition a biochemical factor, a serum lactate over 2. And in cardio shock trial, we found that serum lactate preserves its prognostic value. It's still a useful marker regarding the prognosis. But if you see better the data of cardio shock trial, you can see here that 30% of patients had low serum lactate upon the presentation of cardiogenic shock in emergency department. That means 1/3 of patients had normal levels of serum lactate at the admission to the emergency department with a diagnosis of cardiogenic shock. This is, I think, a significant limitation also for serum lactate for the evaluation of these patients. Thus, we need new biomarkers because the organ injury, if you see here, is very crucial for the prognosis of these patients. The number of failing system is essential in order to stratify better these patients. And if you have biomarkers to identify early the organ injury in these patients is very important in order to maximize the treatments from the admission to the emergency department. Thus, we have new biomarkers like bio-adrenomedullin. What is adrenomedullin? Adrenomedullin is a biochemical factor released intravascular in order to protect during the acute heart failure and cardiogenic shock the endothelial barrier and to inhibit the extravascular accumulation of fluids. That is bio-adrenomedullin, and bio-adrenomedullin, which is the active molecule of adrenomedullin, measured in the plasma or whole blood of these patients, reflect the tissue congestion and the fluid redistribution in these patients. It's something different than natriuretic peptides because the classical natriuretic peptides reflects the intravascular congestion. It means the combination of these two factors is very good combination to detect not only intravascular congestion but also tissue congestion early and to optimize the decongestive therapies. Thus, we have the clinical evidence now that the bio-adrenomedullin is high in patients with residual congestion from admission to discharge. And you can see here also the degree of edema in these patients. The higher value of bio-adrenomedullin is related more with alveolar edema, while interstitial edema is related with intermediate levels of bio-adrenomedullin. And this very nice gradual increase according to the level of edema and congestion in these patients. And here you can see also another very nice clinical publication that the bio-adrenomedullin values can guide also the diuretic treatment in these patients, especially the absence of diuretic therapy at the discharge in patients with residual congestion was correlated with the highest mortality in these patients, while, on the other hand, the optimal use of diuretics at the discharge in patients with residual congestion at high bio-ADM levels was associated with reduction of long-term mortality in these patients. Regarding the cardiogenic shock, we have data also, we have published data from Cardioshock trial. You can see here in relation to serum lactate that this marker, bio-ADM increased after especially 24 hours. It keeps a prognostic value after 24 hours. And especially the reduction of these biomarkers from the beginning to 48 hours is a very good marker that these patients will have good prognosis in hospital prognosis and long-term prognosis. You can see here also the cutoff value of 55. It's the gold number, I think, 53, 55 in all trials. This is the levels that over that levels there is excessive increase of mortality in these patients with cardiogenic shock. In a larger patient population, the Optimum Cardiogenic Shock trial from Alex Mebaza, a trial comparing the epinephrine and mortality in these patients at various vasopressors, you can see here that the sustained increase of bioadrenomedulin in patients with cardiogenic shock was related with highest mortality in comparison to patients with low levels at the beginning and also during hospitalization. At this bioadrenomedulin level also, the median value was 53, is near to 55 from Cardioshock trial. That is a reproducible value for patients with cardiogenic shock. And you can see here also that bioadrenomedulin predicts also the refractory cardiogenic shock and arrhythmiogenesis in these patients. This is very important to predict complications and to have a close monitoring these patients from the beginning, especially if this bioadrenomedulin is very high at admission. And the next thing is the role of bioadrenomedulin to guide the vasoactive treatment. You can see here that is a very good marker to predict response to vasopressors in these patients. Also, adrenomedulin is a marker that causes vasodilatation, and if this activated in cardiogenic shock participates in the vicious cycle, causes further vasodilation. This means that we need, if it's high in cardiogenic shock, vasopressor drugs in order to keep stable the circulation and to restore the peripheral organ injury. In this trial, authors found that it's very nice, good marker, very useful marker to guide the vasopressor therapy in patients with cardiogenic shock. You can see here also another biomarker, the Proenkephalin A, which is the stained fragment of enkephalin 1. Enkephalin 1 is a small protein that stimulates renal function. The penK1 is the stained fragment of this molecule. It's easily measured in the plasma or whole blood. It's a very good marker to predict early than other biomarkers, the acute kidney injury, the renal function worsening, independently of the presence of inflammation, infection, or other cofactors in clinical practice that affect other biomarkers like NGAL, which is also a marker of acute kidney injury. This marker seems to be related also very well with major cardiovascular outcomes in patients with sepsis and also acute heart failure and cardiac disease. This is a trial also from Salvatore Di Somma, two large cohorts, the Malmö cohort and also the great Italian cohort. You can see here that the bioadrenomedulin penKid can predict clinical outcomes in acute heart failure setting. And also there is a good combination between these two markers in order from one side with bioadrenomedulin to densify the diuretic therapy and with the guidance of penKid to avoid the worsening of renal function due to overdiuresis and in order to avoid hypovolemia due to diuresis in these patients. That means with a combination of these two biomarkers, you can create a sweet spot for the optimal decongestion of these patients. Actually, in this great network study by Alex Mebaza, there is also a very good prognostic value of proenkephalin penK1 in patients with acute heart failure beyond the prediction of acute kidney injury adrenal dysfunction. In this plot, you can see that penK1 is a very strong predictor of acute kidney injury and acute heart failure in combination with a past history of renal failure. These were the strongest predictors of acute renal failure in these patients. And finally, you can see here that penK levels lower than 133 had an hospital mortality rate of 2.1. Low in hospital mortality if the penK levels are low in patients with acute heart failure. But if the penK levels is over 211, the mortality rate was 13%, 5 times higher. This is very important for the interpretation of values of penK levels in clinical practice, especially in acute heart failure patients, in order to predict the hospital mortality in these patients. And also penK predicts worsening of renal function in acute heart failure. This is also very nice publication from the two cohorts, from the Italian cohort and Malmö cohort. The penKid levels, if there is high from the beginning, these patients are at risk to presented acute cardiorenal syndrome, acute cardiorenal injury. Regarding the cardiogenic shock, there is a trial from Great Network cardioshock trial comparing the predictive value of penK1 and GAL in patients with cardiogenic shock. Both predict acute kidney injury, but as mentioned previously, NGAL is affected mainly from other factors like infection, like inflammation, like sepsis, while proenkephalin is independent of these parameters. And this explains the next slide that you can see here, a very nice risk stratification combining the acute kidney injury at penK, especially in intermediate risk patients, while on the other hand, then GAL is weak to stratify these patients, especially with intermediate risk here. There is also additive value in critical ill patients and sepsis patients of penK at bio-adrenomedullin. You can see here the area under the rock, the area under the curve. Here is the red line. The red line is the combinations of both biomarkers, better area, larger area under the curve, higher predictive value for mortality, the combination of these two biomarkers in patients with sepsis at critically ill patients. Thus, according to this evidence, I think that the penKid levels is a very early biomarker, earlier at least 24 to 48 hours to predict acute kidney injury in patients with sepsis, critical ill patients, or acute heart failure, in comparison to classical biomarkers like serum creatinine. It is very important to know the normal values. You can see here all the normal populations with these values. The values is lower than 80 picomole per liter. The median value of penK was 45 picomole per liter. At levels lower than 80 potentially is the levels of healthy subjects, while over 80 is concerns patients with abnormal values of penK. And the other important thing is that these two biomarkers can be measured by a point-of-care system, very flexible, very easily measured markers with this machine in 20 minutes from whole blood or plasma. That is means also for research reasons. You can measure also frozen plasma in some cases for patients. And also this is very nice system connected potentially with a central biochemical system in its hospital. I will continue with two clinical cases. I will close my presentation. The first clinical case is a patient with acute heart failure at acute hypertensive pulmonary edema, 75 years old, male patients, presented in emergency department with dyspnea since 8 hours. He reports 2 similar events during the last year. That means it's the third hospitalization for congestion and acute heart failure in these patients, with history of hypertension, under treatment, with overuse of non-steroid anti-inflammatory drugs due to lower back pain since 3 months, with obesity and history of moderate renal dysfunction with previous levels of creatinine on 0.4. Regarding the physical examination, we found that the patient had bilateral rales and signs of congestion with mild wheezing, low oxygen saturation, 92. The initial lactate was 2. The systolic blood pressure was 180 at 90. Increased respiratory rate, high heart rate, tachycardia, and also temperature was normal. There was mild peripheral edema. This is the ECG. No suggested for a new acute coronary syndrome. Stroke. You can see later the troponin levels is left bad branch block in ECG, but the ESOLT, no new from the history of this patient. The chest X-rays are suggestive for congestion, bilateral congestion, potentially alveolar edema in these patients. The echo assessment demonstrated an ejection fraction 40-45. The lung ultrasound also demonstrated B lines, significant interstitial alveolar edema, while there was a mild increase of IVC, inferior vena cava dimension. From biochemics, we can see here that creatinine was on 0.5, no significant increase from previous pre-existing values of serum creatinine. The procalcitonin was low. The NT-proBNP was relatively high, but not so high regarding the AHF adrenal function in these patients. Regarding the AHF adrenal function, possibly the levels for definition of acute heart failure syndrome is over 1080. This is compatible with the obesity of these patients. The troponin was 47, is relatively high, but not suggestive for a new acute coronary syndrome. Regarding the diagnostic and clinical criteria, this patient is a classical patient with acute pulmonary edema with significant congestion without hypoperfusion. But what is the role of new biomarkers? We measured these new biomarkers upon admission to ED, and we found that bio-Adrenomedullin was 57 and penKid was 381. That's these two parameters suggest that the patient has very severe congestion and was at risk for increased cardiac events and also for acute renal injury. We started immediately the treatment with non-invasive ventilation, with CPAP, with IV vasodilator, nitrates, IV furosemide bolus, but carefully in order to avoid overdiuresis. And this treatment guided by adrenomedullin in order to see the decongestion, and also the penKid in order to avoid further increase of penKid in order to prevent the renal failure. In the same way, we avoid interventions with use of contrast in these patients and also stop RAS inhibitors because due to the procedure of diuresis, there is a risk for acute renal injury in these patients because the penKid was very high. If you see here, the patient bio-Adrenomedullin levels were 57. This is compatible with severe alveolar edema according to this trial of Matthias Arrigo. It means that these levels are compatible with severe congestion. And finally, the penKid levels 381 is compatible with the patient increased risk for cardiac event. According to the JACC publication of Alex Mebaza from the Great Network these levels is compatible with hospital mortality near to 13%. This is a patient with very high risk. If you see that the mean mortality in these patients is 5% in hospital mortality, these patients can reclassify in a high risk according to the penK1 levels at bio-adrenomedullin with the risk of death 13%. After the initial approach and treatment, there was clinical improvement of dyspnea, increase of oxygen saturation, lactate remains low, NT-proBNP, high-sensitive troponin serum creatinine remained unchanged after 3 hours. And we found after 3 hours in a new measurement of bio-adrenomedullin, there was the new level was lower than 45. That is the lower level for detection of bio-adrenomedullin in these patients. This means that the bio-adrenomedullin levels was reduced, and this decrease was compatible with decongestion of these patients. And this is very important in order to guide the further treatment and also to avoid the admission of this patient to the ICU. These patients admitted regularly to clinical ward. The next case is the cardiogenic shock case. 70-year-old man presented to ED with acute dyspnea the last 4 hours and confusion, with previous history of coronary artery disease, with previous history of MI, pre-existing LV dysfunction, low compliance to diet restriction, diuretic therapy. There was viral infection before 5 days, non-COVID infection. In clinical examination on ED, there was high respiratory rate, low oxygen saturation. The systolic blood pressure is relatively preserved, 100. High heart rate, tachycardia, bilateral rails, cool extremities. The lactate was on 1.8, was relatively low, not suggestive for classical cardiogenic shock. Not so high NT-proBNP, troponin was 72. The next measurement was also similar. There was no indication for a new acute coronary syndrome. The initial creatinine was on 0.2. You can see here the ECG is not suggestive for a new acute coronary syndrome. There was low ejection fraction, initial assessment by cardiac ultrasound, 20-25%, potentially due to pre-existing MI and pre-existing heart failure, because this patient had a patient with known history of ischemic cardiomyopathy. You can see here also the B lines in lung ultrasound and also some pleural effusions, clear evidence of congestion. And the question is, what is the role of new biomarkers upon patient admission to ED? It's a classical coded well patient. Is it cardiogenic shock? At what state of cardiogenic shock? Stage B or C, according to the new classification. The level of bio-adrenomedullin was 105, very high, and also penKid 397, very high, also the penKid. This suggests also severe congestion, suggests preclinical renal injury, and there was also confusion, brain ischemia in these patients, and also cardiac dysfunction. According to the new classification, these patients belongs to the classic C stage of cardiogenic shock, despite the levels of serum lactate, because in this classification, the classic cardiogenic shock needs a lactate over 2. But if you have at least three organs with injury, and also evidence, clinical evidence, the new biomarkers suggesting hypoperfusion and peripheral organ injury, I think that these patients is classical C-stage cardiogenic shock. And according to this classification, this patient, in this nice publication from my department, you can see here the overt cardiogenic shock needs support from vasoactive drugs, norepinephrine, and also classical anodilator. And in this case, in these patients, cold and wet, with dysfunction of at least 3 organs, stage C cardiogenic shock, with admitted to CCU guided by adrenomedullin at penKid, patient supported with non-invasive ventilation, with IV anodilator levosimendan plus vasopressor norepinephrine furosemide, low molecular weight heparin. And the second value of troponin, as mentioned previously, was suggested for the absence of a new type MI. Thus, we avoided urgent coronary angiography because high penKid levels suggested that the patient was at risk for acute renal failure. After the initial treatment, there was clinical improvement, adequate diuresis, increase of oxygen saturation. There was stable systolic blood pressure. This mild increase of systolic blood pressure came improvement of patient confusion. The serum lactate was relatively stable. It was not increased in the next 3 hours. In contrast, the bio-Adrenomedullin value was 65 after 3 hours. There was over 30% reduction, a decrease which was compatible with the rest of criteria that showed improvement of the patient's state. Now, it means this change can predict the response to vasopressor therapy, and this is compatible also with published data from Optimization trial of Alex Mebaza. Thus, in take-home message, I think that acute heart failure is a clinical condition with high morbidity and mortality. Early recognition of congestion and peripheral organ injury is crucial for the optimal management of these patients, as well as the selection of proper interventions in the emergency department. Interpretation of values of traditional biomarkers, like natriuretic peptides and serum lactate, is restricted by many cofactors in the AD, such as inflammation, infection, sepsis, etc., obesity, age, gender, and other cofactors. Novel biomarkers, such as bio-Adrenomedullin and penKid, are easily measured by point-of-care systems, add early diagnostic prognostic information, which is independent from other cofactors. It can guide optimal therapeutic strategies in patients with acute heart failure upon their admission to emergency department. I will close my presentation. Very nice slide from Alan Meisel. You can see here the progression from 201 to 2022 about the concept of ideal biomarker. You can see here that today the ideal biomarker is a biomarker that's either highly sensitive for diagnosis or highly specific for treatment effect, like bio-Adrenomedullin and penKid, in order to detect acute kidney injury. It reflects abnormal physiology or biochemistry. It also, bio-Adrenomedullin reflects extravascular congestion, endothelial barrier integrity, and also penKid, the early loss of kidney function. Is related to prognosis, is clinically actionable in order to predict prognosis, should be used as a basis for specific biomarker-guided therapy. And especially at bio-Adrenomedullin, this is not only a biomarker to guide therapy, but there are some trials with monoclonal antibodies, and this marker can be used also as biotarget. And finally, biomonitoring during treatment is an effective surrogate of improvement. That I think this final point concerns both the two biomarkers, the penKid and bio-Adrenomedullin. Thank you for your attention.
Thank you, Professor Parissis, for this very nice introduction in the new biomarkers in the field of acute heart failure, and for sharing these two very interesting clinical cases where you clearly show how you manage the patient with the high value of penKid and bio-Adrenomedullin. So we do have already some questions in the chat. The first one is, what cutoffs are used for bio-ADM and penKid in the acute heart failure patient?
I think the cutoff for bio-Adrenomedullin of 45 is okay for bio-Adrenomedullin, at 80 with a mean value of 40, also 45, mean value of healthy subjects in penKid. Yeah. But 80 was a 99th percentile position for healthy population, according to the Malmö trial, the Swedish trial.
Okay, thank you. The second question that we have in the chart is, are there any clinical improvements for those two cases in terms of kidney function, and was there a need for dialysis?
If there was no improvement of renal function in these patients, its potential role for also ultrafiltration in some cases. At this, there are data in literature that penKid can predict patients that need renal replacement therapy. That is also very useful for clinical practice. But I think in the emergency department, it's very important from the beginning to start the renoprotective therapies. First of all, to improve perfusion of peripheral organs by vasoactive drugs. Second, to create an effective decongestion, but to avoid hypovolemia and overdiuresis. Third, to avoid nephrotoxic drugs like contrast. In the second case, we avoided the coronary arteriography immediately in order to avoid also the further renal injury with administration of contrast. And finally, it's very important also the volume status of these patients sometimes. Potentially in the future, it is very useful a trial with regulation of fluids of patients according to the new biomarkers, because very nice to see the intravascular, extravascular volume with bio-adrenomedullin, natriuretic peptides, and also the renal function with penKid.
Okay, thank you. So just a comment from my side, there was no need for dialysis in the end for these patients that you saw in your hospital, right?
Yeah.
Mm. There is another question here. Which clinical manifestation of a patient admitted at emergency department tricks you to measure penKid?
I think it's all patients with severe congestion needs an initial measurement of penKid in combination with bio-adrenomedullin. If you see the data from the initial trial that combines the Malmö Italian cohorts that combines the two biomarkers, I think it's crucial to combine these two biomarkers, especially in congestion patients, because from the beginning, because congestion is a driving factor, a pivotal factor for renal dysfunction, acute cardiorenal syndrome. It is very crucial to detect early this risk with penKid. And also, if you have a marker of congestion, a marker to create the congestion, and also the penKid in order to protect the renal function from overdiuresis, hypovolemia, I think it's nice to combine these two biomarkers from the beginning, like the first case.
Yeah, that's a very good observation. That's true. We have seen also some cases here.
Every patient with severe congestion is at risk for renal function. But the other important value of penKid is that it does not predict only acute renal injury, but cardiac outcomes, according to the JACC trial. And according to the first case, the patient risk based on creatinine was 5% in hospital mortality. But looking at the penKid and the JACC publication, the mortality in this patient was 13, 2 times higher, reclassified as a high risk by penKid, according to the JACC. This is very important also in order to maximize the treatment from the beginning.
Yeah, definitely. Thank you. Another question here. Thank you. From your experience at the emergency department, how do you see the future implementation of bio-ADM and penKid in the daily routine?
I think it's the most important thing that is easily measured markers from whole blood in 20 minutes. That means that if you have a point of care system, emergency department, it's very nice to see from the beginning these biomarkers to reclassify the patient at risk and also to check again, especially in the resuscitation room, after 3 hours, especially for bio-adrenomedullin, because bio-adrenomedullin has a short half-time, very short. It is this is advantage in comparison to NT-proBNP because the NT-proBNP has long elimination half-lives. This is very important to check again in 3 hours in a new measurement the response of the patient except the clinical evaluation. In the same room, in the resuscitation, in the emergency department, with the point of care system. This is very important, that there is point of care system. There is no need for central laboratory for these measurements.
Yeah, that's a very important observation. The other question that we have in the chat, it's also related to penKid. It says, I understand that early detection with penKid can make a difference in critical patients, but what value can it have for patients with minor kidney dysfunction?
It depends why means what is minor kidney dysfunction, because many patients had normal levels of creatinine, but is of high risk of renal failure the next days, because creatinine is no so reliable marker, the change of creatinine to predict acute renal injury. That for me, if there is congestion, if there is hypoperfusion, if there is use of nephrotoxic drugs, despite the normal levels of creatinine, I think that the penKid is useful to predict very early the renal injury in these patients.
So it would be the case to predict subclinical AKI that it's not covered by creatinine, right?
Yeah. 24 to 48 hours earlier than creatinine. And the other advantage regarding the, in comparison to NGAL, is that it's not affected, penKid, by infections, urine infections, or other infections, from inflammation, sepsis, etc. It's independent from these cofactors. And this is, for me, the reason that NGAL does not work in heart failure. And actually, there was negative trial with NGAL, the kinesis trial in acute heart failure.
Because of the comorbidities from the patient. Yeah. Okay. Thank you. Let me scroll here to see whether there is some more questions. No, maybe I add a question from my side. So which time points would you recommend to measure penKid and bio-ADM at the emergency department? Because you mentioned 3 hours after the admission, but maybe you can comment.
Upon admission, in order to have very early risk stratification from the beginning, and also at 3 hours, and possibly if the patient is in ICU or clinical ward, the next day after 24 hours, the third measurement, in order to see the exact the effect of drugs to congestion. If there is also, or a discharge, in order to see the residual congestion at discharge.
Okay.
But for emergency department, I suggest upon admission after 3 hours, if the patient remains to emergency department in resuscitation room.
All right, thank you. Someone's typing, and I cannot see the question. Okay. You mentioned the clinical presentation of acute heart failure like pulmonary edema, ventricular failure, or cardiogenic shock. Do you think that these both biomarkers, penKid and bio-ADM, could be used in all those clinical presentations?
Yes, because congestion is also present. Is also present in all these scenarios. For example, cardiogenic shock also involves congestion, pulmonary edema. Acute hypertensive pulmonary edema is a classical acute heart failure scenario, and also acutely decompensated heart failure. The only scenario that something is a little bit different is acute right heart failure, because mainly acute heart failure, right acute heart failure, presented with peripheral congestion. But if the bio-Adrenomedullin reflects tissue congestion, it's also useful, not only to identify pulmonary congestion, but tissue congestion. On the other hand, acute right heart failure is accompanied very frequently with renal dysfunction due to elevated systemic pressures, elevated pressures within the renal veins, that is main factor for cardiorenal syndrome in this patient. That also is useful, the penKid in these patients. Thus, I mean, in all these 4 clinical scenarios, these 2 biomarkers are useful.
To stratify the patients at the emergency department. Okay, let's see if there is some more question in the chat. Let's scroll here now again. Yes. So someone's typing.
Another comment is possible comment is the role of lactate. Many times we in a resuscitation room we have patients without significant elevation of lactate, but we have the sense that these patients is hypoperfused patients. This is also a concept, a new space for the role of new biomarkers. So to detect earlier the hypoperfusion despite the levels of serum lactate. And also in a Cardioshock trial, we published the data that 30% of patients with cardiogenic shock, typical cardiogenic shock, had serum lactate lower than 2 picomole per liter.
Okay, that is an interesting observation. We have another question here. What are your experience to include the new biomarkers in your department? And can you give some insights into this process?
What is the role?
What is your experience to include the new biomarkers in your department? And maybe you can share your insights in this process.
Now we have the use of, we use these biomarkers under research protocols, and also we are in the phase of investigations. What is the optimal timing? The optimal timing for use. Personally believe that is not useful. They are not useful only for risk stratification, but also to guide the treatment. This is the reason for a new measurement after 3 hours. But we have a lot of experience. But we are at the beginning investigating the exact role. And soon we'll publish the data about our experience in this topic.
Okay.
The other thing is we compare these biomarkers with lactate, natriuretic peptides, and other biomarkers in order to see the exact additive value in the emergency department.
Yeah, definitely. I do not see someone typing or any further question. Let's wait 1 minute. So, yeah, maybe you can give us a final message on your experience exactly in the emergency department for many, many years with acute heart failure patients. How do you see this both biomarker together in the coming future as you are expanding your department in your hospital and hopefully in the whole Greece?
Yeah, I think also this take-home message is very useful. I think it contains all this information. I think that it's a difficult situation. It's a heterogeneous group of patients. It's mainly the congestion is the main factor that leads to hospitalization, but there are some patients, about 10% with hypoperfusion. And hypoperfusion is very difficult situation to recognize. It is related with high mortality. It's very crucial to detect early this condition and to treat early this condition. That I believe that we need new biomarkers. There is space for new biomarkers because the classical biomarkers have many limitations in clinical practice. We need new biomarkers independent of cofactors of comorbidities. And I think that penKid Adrenomedullin are promising biomarkers for clinical practice. And I think in the future, I think it will be useful to be part of our clinical practice in the emergency department.
Okay, Thank you very much. It was very clear take-home message. And thank you again for sharing with us your experience on penKid and bio-ADM. Thank you all the attendees for your time. As I do not see any further questions, I would like then to close the webinar and wish you a nice evening. And thank you again, Professor Parissis, for your time.
Thank you for the invitation, and thanks the people that watched the webinar.
Thank you.